Thank you very much, ARCS, for selecting this abstract. It's a pleasure to be here talking about this topic. My conflicts of interest is I'm the founder and CEO of Avenues. And today we're going to talk about measuring success. Now, measuring success in IVF in particular is fascinating because we all know outcome matters, right? But no one seems to agree on how to count it. So measuring success matters because how we choose to define it will then tell us what we're going to be able to achieve. So when you're choosing what's going to be the KPI they're going to use to be the headline, you want it to achieve two things for you. Firstly, it needs to be sensitive to operational deficiencies. It needs to be able to pick up when things are not going well in your clinic. It also, more importantly, needs to be aligned with what the patients want, the patient's needs. It needs to help us fulfill the patient's needs. So if you go on PubMed and you start searching what are the KPIs that are used out there as headlines, or if you're looking at the national registries around the world, they tend to use traditional KPIs, which are kind of defined on a numerator divided by a denominator that expresses a fraction, which you then compare across different clinics using a percentage. In the denominator, we tend to put something to do with the baby, right? So the live birth baby is what the patients really want, but you might want to get a faster result with the biochemical, clinical, ongoing pregnancy rates. And what you can also do is on the denominator, we tend to use the procedure, cycle started, egg collection, transfer per embryo transferred. This is what we traditionally do, not just to run clinics, but to run RCTs. But the key one that we should be really looking, because very few of our patients will have a single egg collection or a single embryo transfer. They invariably will have a longer journey than that involves multiple procedures. So the Americans, they use the patient on the bottom denominator. So they look at live birth rate per patient. And that's across all of these traditional KPIs seems to be the one that's most aligned with the patient's best interests. But then David Sable came along. And he said, I don't want to have the baby in the denominator. I want the baby in the denominator. And now I want to know the cost per baby, the time to baby, and the convenience to baby. And ultimately, this is what your patients want. None of your patients are sitting there at 5 a.m. taking a stimulation injection thinking, I hope this improves my live birth rate per embryo transferred, excluding PGT-A, right? They want to know cost to baby, time to baby, convenience to baby. So if we as professionals, whether it is the regulators with the HFEA new ranking system that they've just put out, or whether it's when we're running RCTs, or whether it's as individual clinicians telling a patient whether technology works or not, if we're using traditional KPIs and the patients are expecting the David Sable KPIs, is there a problem when the two of them are not matching? And turns out there is a problem, because when you ask a stupid question, you get a stupid answer. Ultimately, the patient pays a price. And a good example of that is the HFEA traffic light system. If you're going to put it into a box that it needs to fit, that it improves per cycle, the live birth rate per cycle started in a single cycle, you're not going to find improvements in technology such as PGT-A. That's not how the technology works. That's not where the benefit comes from. And then we go off and we publish no evidence to support the use of this technology. And then the NICE guidelines comes out. This is the draft version that's come out saying do not offer PGT-A as part of fertility treatment. The implications of how we chose to define success are now going to mean that no NHS patient is going to be able to access this technology, even though the vast majority of us in our clinics offer PGT-A because we know the value that this technology is able to bring when used correctly to the right patients. But this is the consequence of having the wrong definition of success. So we have a poster out there, which feel free to go and have a look, where we've gone systematically to look at each of these definitions of success that are commonly used. We measured down here, how is it that these pick up anomalies, low blastulation rates, low fertilization rates. If you have an ICSI practitioner that's really good at head over heels over other embryologists in terms of FERT rates post-ICSI, right? How well does these KPIs that we're using in headlines, how well do they pick up these anomalies? The fact that we cancel more patients before egg collection because of poor stimulation decisions. How well do we pick up those issues with the KPIs that we have? We then looked and compared these KPIs across multiple dimensions, looking at how easy it is to use to measure this KPI and how easy it is for clinics to manipulate the KPIs, right? So how can we have strategies to boost your success rates? And ultimately what we found was that live birth per patient per period of time seems to be the traditional KPI that's best aligned with the patients whilst being reasonably easy to be measured. So how has the HFEA chosen their success rate? So if you go pre-2010, it used to be births per embryo transfer. And then we had ARGC had the highest success rates by far. They transferred multiple embryos, lots of multiple births. And then as a few years later, the HFEA said, no, we don't want any more multiple births. This is a huge risk associated with IVF. Let's change the KPI now per embryo transferred. This now changes who's first on the ranking. It affects the decision and the interpretation by the patients of what is a better clinic or a worse clinic. But actually the clinic continued being just as good as before. It hasn't reduced its capability. We just changed its position in the ranking because we changed our definition of success. But last week, HFEA has come up with a really creative one, very colorful. Birth events per egg collection procedure. But we're only going to follow it up to 2 years after you've had your egg collection. It's cumulative, but up to 2 years. So if you have a really good ICSI practitioner who got 10 out of 10 on their ICSI, and all 10 happen to be viable because they're that good luck getting those 10 babies in those 2 years, right? It's just not going to... You might as well just get 2 out of 10 because that's what you're going to have time to transfer to the patient into that time period. So this is not going to be sensitive enough to pick up on these subtleties. You then are excluding donor eggs when, donor eggs, if you base it based on the age of the recipient, of the donor instead of the recipient, you can normalize aspects to do with that. But then they decided that on the births per embryo transferred, they're going to exclude PGT-A. Now I'm scratching my head on how I'm going to explain to my patient that you're going to exclude PGT-A from births per embryo transferred when they're on the traffic light system. They're saying that it's a red on the traffic light system because you're using a different definition of success on the traffic light system. So now you have different definitions of success in different parts, giving you different opinions. If we can't make heads and tails of this, how are the patients supposed to understand this? So our suggestion is that should be live births per patient for a period of time, plus cost to be time to baby, convenience to baby. Now, to get cost to baby, we're going to need to be happy as clinics to share what has been the cost for this patient to get to this stage of their treatment. We send about 50 data points during the HFEA submissions. It's one more, right? And most of the clinics are able to quantify that. We're already monitoring that data anyway. And when it comes to the traffic light system, it shouldn't be on a per cycle basis. It should be, does it bring value to patients, full stop? We already have a mechanism to evaluate whether this is fulfilling the claims associated with the technology. And that's what the MHRA governs through the CE marking, CA marking, if in the US, the FDA approval, right? So why are we creating a completely different messaging going to patients, which is different to our regulatory pathways for technologies? So I'm going to go for a few cases of what does this mean. So same patient, single embryo transfer, double embryo transfer, no transfer, okay? Which of these strategies are we going to go with this patient? So in the first single embryo transfer, one at a time, it's going to cost them £35,000 to get to this baby. The first 6 embryos that they have in the first cycle, they just aren't viable. But you're going to go 1, 6 times until you get to eventually do your second cycle and off you go. For the double embryo transfer, we use some technology. I don't know, name it PGT-A or name it embryo assessments using AI, or we're really good at morphologically assessing, whatever it is. We've established that these have a very low chance of a multiple birth and a very low chance of implanting. So we're going to go 2, 2, 2 because we don't want the patient to have to go through 6 negative cycles before we go through another egg collection. So this now reduces the cost to $25,000 and they're taking 8 months to get to their baby. But if we're really trusting that technology, like we trust PGT-A, for instance, saying it's all aneuploid and we're going to go straight to another cycle, They have egg collection 1, no transfer, straight to egg collection number 2, and now it costs $17,898. They got to their baby in 4 months. But the KPIs that the HFEA are using here are not sensitive to pick up on this. Cost to baby, time to baby, convenience to baby. That's what matters. Another example, poor ovarian reserve patients, the majority of what we're dealing with on a day-to-day basis. So I'm going to start by doing 1 egg collection at a time. 1 egg collection, do all the FETs. Another egg collection, do the other FETs. So you're going to get 1 egg here, 1 egg there, 3 eggs here, right? So these are poor ovarian reserve. 48,141 to get to the baby, 18 months to get there. Next, I'm going to do 3 egg collections. Maybe you're going to do but this time I'm going to use PGT-A. So we're not doing the transfers until we get to the viable embryo. So this now brings it to 8 months, 32,000. Lastly, I'm going to do a triple egg collection. Okay, so this is the package that we do we did a calculation of what is the cheapest way to get to that baby for patients of low ovarian reserve. And that was a triple egg collection with PGT-A on your top 3 embryos. That brings them to 18,149. They get to their baby in 4 months on average. And then off you go with having the different conveniences that the patients are experiencing. These are just examples for you to see what does this mean in clinical practice. What we actually did was a mathematical modeling where we're looking at what happens with each of these KPIs on clinics that are identical to each other in terms of their capabilities, but we're just changing the different strategies that we might be applying. Things like if you have 2 poor quality embryos, you're going to transfer them 1 at a time, or you're going to put them in as a double. Or in the other scenario here, the impact on the patient values, the David Sable KPIs. So we did this mathematically so that we could look at all these different scenarios in an agglutinated way. And here are a couple of things that kind of came up, right? Here's like your instruction, your recipe. If you want to boost your success rates with the current definitions of the HFEA, this is what you should do. But big warning that this is going to harm your patient's best interests. So number 1, excludes the poor prognosis patients. BMI over 35, don't treat them. Okay? So they're going to have half the chance of success to your patients of normal BMI, so exclude them. Next step, you're going to take prematurely steering patients towards donation, right? So donation is excluded. So put those patients that are going to be harder to get pregnant, even though you could have given them a shot with their own eggs, bring them over to donation. Encourage donation in order to boost your success rate. Another example, not offering any PGT-A at all. Just cut PGT-A completely from your program. Next one, avoid minimal stimulation. Yes, it's a really good strategy to reduce cost, but avoid it because you wanna get as many eggs as possible so you can get that cumulative, the first 2 years to try and get a baby in there. OHSS will go through the roof, but that's not a KPI we're measuring, okay? Next one, excluding clinical strategies that require multiple egg collections. Forget dual stem, the triple egg collection that we do in Avenues. Forget all of that. You're gonna have to do things 1 at a time because on the per egg collection basis, your success rates are gonna drop. Discarding good morphology embryos and not culturing to day 7, because we know that day 7 embryos have a lower chance of leading to a baby. You're getting the picture, right? So single embryo transfer, even if a patient has really low quality of embryos, avoiding the double embryo transfer. And you know that they're not going to get a multiple birth from that particular case. Canceling stimulations when egg collection should have been attempted, right? Because we're measuring per egg collection. So you might as well not give them that shot on that egg collection because you don't want this to count. Pressuring patients to transfer frozen embryos within 24 months when they're not quite ready. Pressuring patients to transfer frozen embryos rather than starting a new egg collection cycle. None of these should be done by anybody in the room. But these are the sort of practices that what you measure is what you get, and what you measure encourages behavior. And this is why we cannot have the KPIs as they currently stand. And we're very proud at Avenues that we couldn't give a rat's ass where we sit on the rankings. We have our own definitions of success, and that's what we're going to be using with the patients, because 2010, 2025, and now, the rankings will change and the definitions of success will change. So we as a field need to start aiming, if the HFEA got it wrong, we need to have the right success that we provide to our patients. So traditional KPIs, as we've demonstrated, are vulnerable to strategic manipulation. They're insensitive to operational failures, and they're not aligned with the patient's best interest. And in that scenario, what's the point of having them? brings a very big risk of shifting behavior away from serving patients and towards serving numbers. And that's not why any of us came into what we're doing today. So I've had a lot of conversations with the HFEA during this conference. They are having the conversations. I would like all of you to also have those conversations, because I remain extremely hopeful and not delusional that the HFEA will rethink these success rates, and they will bring success rates that are much better aligned with the patient's interests. So I never do a take-home message, but I'm doing it this time because I have a wish list, right? So with the HFEA, I want them to focus on, does this technology bring values to patients? I don't want to include PGT-A here and exclude PGT-A there. I want rankings that are aligned with what the patients want, but also are consistent when we're measuring technology or clinics. I want the HFEA to become the engine of innovation, of responsible innovation. For the fertility clinics, for you guys, I want you to prioritize patients over rankings every single time with every single decision making. I want you to look at every single RCT that's coming your way and have the critical thinking to think, is this asking the right question for what this technology is capable of so that I can bring the best value to my patients? So I want to thank the amazing Avenues team, because it's really this mindset of, I don't care that something's written on a piece of paper. I don't care if it's the law. You change the law if you need to, and you change what's on the piece of paper so that you're always serving the patients first. Thank you very much.
Thank you very much, Cristina. Is there any questions at all?
Cristina, congratulations. That's the most amazing talk I have heard. Partly because I've been grappling with the same situation for many years, especially after the NICE guidelines came out in 2010. And we were basically victims because we were performing IUI. Yeah. And we had no real comparison between IUI data against IVF data. And yet NICE, without evidence, said, therefore, do not do IUI, do IVF. And since then, in my most recent paper, which is going to come out soon, I begin addressing the same question that you are addressing, and that we have to begin addressing what is real success rates, and that is per woman.
Yeah.
And just so happened that we are overlapping on this one, and I've been highly critical of the cumulative success rates. Yeah. The other thing that I found is that in the old days, we used to have clinics could be compared for patients against, so they could formulate which clinic to go to. The HFEA presented the data in such a way that you cannot compare two clinics. And I'm a bit worried about it. So your talk is really in the interest of patient welfare. Congratulations.
Thank you. Appreciate the comment.
Okay, just last question, just in the interest.
Cristina, thank you very much for the excellent presentation. I agree with most of what you said. My only concern is about PGT-A, because we've just seen evidence to suggest that it could reduce the cumulative live birth per cycle started. Mm-hmm. We don't really have any sufficient evidence to suggest that it's useful for patients. So I'm not sure how we can promote it so heavily.
The reason why I joined that conclusion is that because you are defining it on a per cycle started basis. That's what all the evidence is looking at, because you can't really run an RCT across multiple cycles. It's going to take too long to do so. We believe that RCTs are not fit for purpose in the IVF sector for that very reason. So we believe that if you're looking at something like PGT-A or AI assessment of embryos or any assessment of embryo, what you need to know is, does it have prognostic value or does it not? We all know that there is like a 60 to 70% chance that this embryo is going to implant if it is a euploid embryo. And this is consistent irrespective of a patient's age. Do we all agree with that fact or no? Is this something that we're all in the room, or do we don't agree with that number? Yeah, there seems to be a lot of nods, right? But if you now try to say, tell me if that increase is per cycle started, no, because analyzing the embryo is not going to improve the embryo. But knowing that this embryo is aneuploid, right? And you can move on. That means that you can move on to next cycle, as in the examples that I gave. The issue that we have is that we had problems of making wrong clinical decisions with mosaicism, for instance, or working with genetic labs that weren't as effective as they should be, or the old versions of the technology, the fish and so on. But that's not to say that we agree that this right now, today, with all the technology that we have, and I am the biggest AI advocate, PGT-A is still the highest area under the curve in terms of prediction of whether an embryo will become a baby or not. More than any other measure, more than AMH, more than patient age, knowing if it's euploid or not is the most powerful tool that we have. What's missing and why we're not reflecting in all of those RCTs and why we don't have the evidence is because we're trying to move it onto clinical intervention, which is not the PGT-A. It's what we did with the information. The fact that we chose to discard the mosaic embryo. That was the wrong thing. That is not the technology's fault. That is us making the wrong clinical decision with the information. It's like giving the patient the wrong dose because you got the wrong AMH on the patient. That's not to say AMH has no value. It's just to say that we need to fix the way that we're receiving the information and what is the clinical intervention that we do. Turns out that discarding mosaic embryos is not the right approach. The same goes with 1PNs. How many 1PNs have I discarded in my career, only to then discover that if they make a blastocyst, they have an equal chance of being euploid, an equal chance of becoming a baby. That's not to say that you shouldn't look at PNs. That's to say that I finally made the right clinical decision once I learned the data associated with it. But that was, 15 years into my career, right? So as an example, the way that you assess it is, does it have prognostic value? And that you don't need an RCT. You don't need to spend £2 million to run an RCT on it. You need to know what is the prognostic value, okay?
We're going to have to move on, Cristina. Okay, thank you.
But we'll have lots of discussions after. Thank you.